GI physicians are making these assessments today because the risks with midazolam are not lower magically, and they're making these assessments, and sometimes they're not doing all that well. And I don't know about your hospital, but I'll tell you at Stanford, there's a code blue in the GI suite, every other day. And maybe we just get them all at Stanford. And so this is a chance to advance care because they are doing patients right now that they shouldn't be doing without us. And I hope that in every place where Sedation is deployed, the anesthesia department will become involved and will take a very active role in teaching their GI colleagues when we're needed and when we're not needed, and what to look for in the problem patient, and to help them with this screening assessment. And ideally, hopefully, we can even get somebody to pay us to help with this, because it's a real service, to advance their care by helping them with that screening question. It's a critical question, and we can advance care from where it is now by taking an active role in teaching them.
I think it's a good one for Dr. Hannenberg. I mean, I think those necessity guidelines are a good basis.
All is not an acceptable answer.
No, that is definitely not my bias, and I think those algorithms are a great place to start thinking about it. And the fact is that numerically, if you exclude a completely healthy patient having completely standard screening studies, you wind up with a population that probably does merit the care of an anesthesiologist, and it merits the care of an anesthesiologist in a way that nobody contests.
Perhaps I didn't clarify, and this, Carl, addresses your point a little bit, and also this patient selection issue. The product labeling does exclude, it's specific for ASA 1s and 2s. It excludes ASA 3s and above. And in part that's because the pivotal trial really just didn't have enough ASA 3s. The pivotal trial really was healthy, non-obese patients who were ASA 1s and 2s. And so that was the basis of the approval. And to expand that label, it'll require more data.
Yeah. And then quite clearly, and also explicit in the label, patients who need deep sedation. If a patient needs deep sedation, they need an anesthesiologist. And I don't envision that changing at all in this paradigm. If the patient has risk of airway obstruction, patient with a big beard, patient with some sort of unusual airway anatomy, that needs an anesthesiologist. So these are basically patients who are not at risk.
Don't you think that it's very different if there is an opioid on board or not? Or in other words, don't you think that people having an opioid on board need an anesthesiologist because of the huge synergism on respiratory depression when both drugs are used together, and also on the fact that sedation is not anymore a good monitoring of sedation?
The answer is absolutely. And when we look back at some of the data from the trials, the patients who desaturated often were in the standard of care group, and it followed a dose of opioid. And we see that in the operating room every day. The person's breathing fine, and you give them just 25 mics of fentanyl, and they have been breathing spontaneously, and now they're going to be on a ventilator for the next 10 minutes. You go, why did I do that? So we all see this. So the instructions are very precise, and it's going to be emphasized again and again in the training. Patient gets 1 dose of opioid up front, and then no more. No additional opioid. It's a dose of opioid from 25 to 100 mics, depending on the patient status. It's given before the propofol starts. There's then a 3-minute delay, so that gives you time for peak effects, so the opioid's always washing out when you start the propofol. And if you don't do that, your propofol doses double. It has a huge change on the efficacy. And so when Ethicon first got into this, they discovered, as did Rex and his colleagues, that they were going up to 150, 200 mics per kilo per minute. People were breathing, but it's a ton of propofol. So you have to give, when you give opioid, you actually cut that in half. So you need that one dose of opioid, but you never touch it again. And if you want to touch it again, you call in an anesthesiologist and say this patient needs some opioid, but you don't give it again yourself.
I think probably that represents the biggest possibility for circumventing the device's safety features, is a redosing of the opiate, Valerie. And so that's certainly a worry. Because that would represent off-label use and a departure from the education related to the device, but people could certainly do it.
Just to reiterate what Alex just said, you don't have any syringes with you. No opioid, no midazolam, no additional propofol just to sort of slam it in if you aren't happy with what the machine's doing. All of that is absolutely verboten. And it is one of the reasons that the device isn't for sale. The device that it'll be licensed out to people, but J&J or Ethicon has the ability to go and pull it back. They're not looking for trouble, and if they find evidence that people are circumventing it, they'll pull it back. It's just not worth it.
Yeah, I don't get that.
So where do you see that going, and are we putting ourselves at risk for being part of a system in which we are
The question was, what is the FDA actually telling us? Because the package insert remains unchanged, only by those trained in the administration of general anesthesia and not involved in the conduct of the procedure, yet a device intended to be used by an individual participating in the conduct of the procedure and maybe trained in the administration of general anesthesia, because I understand there is a prescribed training required, but it seems like so many of the statements around this to be in conflict.
I think I can answer the question. Look, what the law says is that for a label to be what's called mutually conforming, it has to agree in the dose, the indication, and the route. So Sedasis is giving propofol at an approved dose for an approved indication by an approved route. The warning doesn't have that force. You said it was illegal, but it's actually not illegal. That's the FDA's statement, but it doesn't preclude people doing it. The FDA does warnings all the time, and we choose to pay attention or not. It has no force of law. And so the propofol, the Sedasis label, as long as it is consistent in dose, indication, and route, does not have to be consistent in all the warnings. There's actually a lot of examples of other drug categories where there's another delivery system. I mean, tacrolimus. The label for tacrolimus doesn't include it being eluted into your arteries. So there's lots of drug products where the label and a device-administered label are actually different labels as long as they agree in those three categories.
Yeah. I think the other thing you have to remember, just quickly as an addendum to that, is that the process by which a drug's label is changed is initiated by the owner of the label. Yeah. And that's why the petition by the GI societies was sort of a silly effort, because it's the owner of the label that can initiate a change, and that becomes the problem for these older drugs. Nobody is motivated to change the label because there's no revenue stream to support any data gathering that would be filed to get the label changed. So that's sort of a non-issue. You almost have to view the new statements with regard to a drug's administration as addendums to the existing label, because if it's a generic drug, that label will not change for practical purposes.
Yeah. Like I mentioned, pain management. It'll never appear on the propofol label. Why? Because it's a generic drug. Nobody's, no company wants to, there's no financial return to do the studies to change the label.
Yeah.
Thank you. I have a question for Dr. Hannenberg. I'm Kate Leslie. I'm a former president of the College of Anaesthetists in Australia.
Nice to see you.
The slide that you presented implied that approximately a quarter of the billings in America are going towards 3 procedures, and the same is for Australia. And what my question is,
I think that the work that anesthesiologists should be doing should be commensurate with the kinds of training we have. And I'm just questioning whether that chunk of modern American and Australian anesthetic process meets that criterion. So this is probably not so much an issue in Australia, but a lot of our colleagues around the States are terribly frustrated and even angry about the fact that other physicians and the public don't recognize us as physicians and don't understand that anesthesiologists are not nurses. And I think that if we practice in the way I've described and continue to do so, that kind of confusion and loss of stature as a medical specialty seems inevitable. So I think we should be doing hard stuff. Now, I completely understand, and the reason I put up the figures with all those dollars is that I understand what a barrier that is. And people would argue that if you said, well, anesthesiologists are going to do the hard stuff, the complex cases, the sick patients, well, that means, greater medical legal risk, greater Medicare population and reduced revenue, and probably a need for fewer anesthesiologists and therefore a change in market forces. So believe me, I understand, and I understand even without 50,000 members shouting at me about this. I understand what the barriers are, but I still think, looking in the long term, there are serious implications for particularly the pace of growth of these kinds of services in our specialty. Thanks.
Not going to be sold. Who's going to pay how much for the use of this device? And secondly, why was there no EEG monitoring such as this attached to the monitors?
I'll take that on. I don't have any knowledge with regard to the price point and the business model. I've never spoken with this to any of my contacts in connection with my consulting with Ethicon, but the Wall Street Journal article said about $150, and they've said it was reliable sources. So that's an interesting number, and I think that's the first I've ever heard anyone speak of it publicly. The second question was, the BIS. Oh, yeah. It seems to me that it doesn't make a lot of sense to include a surrogate of sedation when the goal is to have a responsive patient. And you don't need a surrogate when you have a clinical measure. So I think that was the position of the advisory board. I don't know that we discussed that in any great detail, but when you're targeting sedation, it doesn't make a great deal of sense to have a surrogate of sedation because you can clinically assess it pretty reliably.
Is there any data about the numbers of procedures failures under sedasis? Because what happens when the propofol infusion is turned off to the patient, patients wake up and then the procedure stops?
Procedural failures.
Oh, procedural failures.
Procedural failures.
You stop and come back.
Oh, I think this was your question that you were going for, but you didn't get a chance to ask it. What happens if you're in the middle of the procedure and you got to go to deep sedation? And the answer is you back out. It's choice one. Or what I think needs to happen is I think, frankly, the right model is a model where you have anesthesiologists covering a suite of rooms, and we're there. And we just come in and we just take over. And that would work at Stanford. That would work, I'm sure, at Utah. And frankly, that's what we do at Stanford. That's probably what you do already at Utah. I think the model of the colonoscopist in a box sounds like a terrible Christmas present. I think the colonoscopist, in a little doc in a box thing, I don't know that that's a safe model. Maybe that model needs to go away. And these really do need to be done in suites where there's in medical centers where there's. Wait, Stu, you think that's crazy?
Alex told us that the profitability of the outpatient surgery center is more than twice what it is for your
Well, then they need to hire, in my view, they need to hire an anesthesiologist and have them there to come in and take over. Because what you can't do is you can't just say, well, I'm just going to push ahead, you know, and pull a syringe of propofol out of my pocket because the machine keeps dialing it down. That's forbidden.
You know, if you could create a viable business model to reimburse anesthesiologists to be available with a certain economy of scale for rescue, then you can do away with all the medical necessity assessments because it's real-time assessment of medical necessity. You know, when you need them, you need them.
You can get that legislated. It's built in, and this is actually a profitable device for colonoscopists. You may actually change the model.
Yeah.
But the way, if you're talking about plugging it into the current model, I see serious potential for trouble.
Yeah, so I mean, I'm not sure what you meant by legislated and whether you were referring particularly to the Affordable Care Act, but the fact of the matter is that in an accountable care organization or global payment model, particularly if you're going from an environment where you have lots of anesthesiologist services to this kind of model, you can easily come out way ahead with respect to your population health budget if you did the kind of thing Steve is suggesting. So to a degree, you know, like the ACA or not, it's creating the financial incentives to make those kinds of changes.
I just wanted to bring up my experience with propofol, and when we launched another indication, we had a lot of trouble with anesthesiologists. They actually kicked some of the sales reps out of our hospital because these people weren't trained in the administration of general anesthesia, and that's for the ICU indication. So we got 3 or 4 indications in the ICU, neuro, cardiac, and so it's kind of parallel to that. And I did write that you must be trained in the administration of general anesthesia and not involved in the surgical procedure. And I would very much encourage strong credentialing to go along with the access to this device. Because I think it could fail, and all of Steve's future visions would be mired in quagmire. So I think that the company should really look at a strong development and credentialing program.
Okay. No further questions. I'd like to thank our panelists. Great presentations. Thank you very much. And thank you for the audience for your great questions. We are going to adjourn to a reception, and I'm assuming that will be held out here in the foyer for the next hour. Please join us at that reception.